Singh is there? Dr. Rachitra Sogi?
Okay. Good morning, everyone. I'm Dr. Indira Durai, and I'll be presenting about few cases with iridochisis and coexisting glaucoma, highlighting the role of anti-segment OCT in diagnosing this condition. Iridochisis is a rare condition characterized by separation of anterior iris stroma from the posterior stroma and muscle layers. Patients with iridochisis are at an increased risk for developing complications such as acute angle closure glaucoma, cataract, and corneal decompensation, which may even lead to blindness. Both intraocular pressure and the iridocorneal angle may appear normal in these cases, thereby complicating the prediction of potential problems such as angle closure glaucoma or corneal decompression. More than 2/3 of patients with iridochisis have glaucoma, primarily angle closure glaucoma, although chronic open angle glaucoma or plateau iris configuration has also been reported. AIOCMT is a non-invasive high-speed imaging modality that provides both quantitative and qualitative insights on the cornea, anterior chamber angle, iris, and crystalline lens. Diagnosing iridochisis can be difficult, but AIOCMT is a valuable tool in confirming the diagnosis, especially in atypical cases and detecting coexisting associated angle closure. Our first case is a 78-year-old male presenting with bilateral defective vision. Anterior segment examination revealed shallow anterior chamber depth with a classic shredded wheat appearance of the iris in the inferior quadrant in both the eyes. Fundus examination and intraocular pressure was normal in both the eyes. Gonioscopy revealed occludable angles in both the eyes. Anterior segment OCT showed typical features of separated anterior iris stromal fibers freely floating in the anterior chamber, almost touching the corneal endothelium with an intact posterior pigment epithelium with narrow angles, thereby confirming the diagnosis of iridochisis with narrow angles. This patient was then advised YAG peripheral iridotomy in both the eyes to relieve the pupillary block component. Our second patient is a 58-year-old male presenting to us as an ocular emergency with symptoms and signs suggestive of acute angle closure glaucoma with advanced glaucomatous optic nerve damage, raised intraocular pressures in the right eye with shallow angles and normal intraocular pressure suggestive of primary angle closure suspect in the left eye. Gonioscopy revealed occludable angles with peripheral anterior synechiae. The patient was immediately started on topical and oral anti-glaucoma medications. Anti-segment OCT revealed disrupted anterior iris stroma with an intact posterior iris layer in both the eyes with secondary angle closure, though iridochisis features was less prominent clinically in the left eye. The diagnosis was now revised as bilateral iridochisis with acute exacerbation of chronic angle closure glaucoma in the right eye and chronic angle closure in the left eye. This patient underwent NDR laser iridotomy in both the eyes and treated with fixed combination therapy in the right eye. A third patient is a 66-year-old patient, male patient, who was already diagnosed with open angle glaucoma and was on anti-glaucoma medications in both the eyes. He did not give any history of trauma, laser procedure in either eye. Anti-segment examination revealed shallow angles with iris chafing in the infratemporal quadrant in both the eyes. Fundus examination revealed advanced glaucomatous optic nerve damage in the right eye with a normal disc in the left eye. Intraocular pressure was higher in the right eye and normal in the left eye. Gonioscopy revealed occludable angles with intermittent peripheral anterior synechiae in both the eyes. Anti-segment OCT revealed rarefaction and cleavage of the iris stroma, but without iris splitting, with an intact posterior pigment epithelium, causing a forward bowing of anterior stromal fibers, thereby obstructing in the angle. This patient was then treated with both eye YAG peripheral iridotomy and anti-glaucoma medications was stepped up in the right eye. At present, IOP is in the target range with medical management. So coming to iridochisis is typically present in the 6th to 7th decade of life as a bilateral symmetric progressive cleavage of the iris stroma, most commonly found in the inferior quadrant. The exact cause is unclear, though it may be age-related, worsened by proteolytic enzymes from glaucoma, or triggered by trauma causing elevated intraocular pressure that splits the iris stroma. Iridochisis is linked to glaucoma in 2/3 of cases, especially angle closure glaucoma, though the exact mechanism is unknown. Hypothesis includes pigment clogging of the trabecular meshwork blocking by free floating antistromal fibers, pupillary block by posterior stromal fibers. It is still unclear whether glaucoma causes iridochisis or iridochisis leads to glaucoma. The treatment is similar to angle closure glaucoma and includes a YAG laser peripheral iridotomy to relieve the pupillary block component. Cataract extraction with goniosynucleosis can be considered as an option in patients with concurrent visually significant cataracts. More invasive interventions such as trabeculectomy or glaucoma drainage devices is reserved for refractory cases. The differential diagnosis includes eye syndrome and Axenfeld-Rieger syndrome. Eye syndrome typically presents in the third to fourth decade. It is usually unilateral and progressive. ASOCT may show narrow angles but without iris splitting of the stromal fibers, whereas Axenfeld-Rieger syndrome presents at birth is non-progressive, asymmetrical, and ASOCT may show significant stromal thinning with iris hyperplasia. So iridochisis is a rare disease with a potentially blinding outcome. The management focuses on screening for and managing ocular comorbidities such as glaucoma, cornea and lens abnormalities. Anterior-segment OCT provides both quantitative and qualitative measurements with cross-sectional views of anterior segment structures in a single scan, which makes it ideal for diagnosing concomitant iridochisis with angle closure disease. So gonioscopy is important for all cases in these patients, as occludable or cynical angle closure may be present, necessitating prompt ARC laser PI. Early phacoemulsification should be done with ample use of ocular viscoelastic devices for easier surgery in these challenging cases. Since iridochisis is a progressive condition, regular follow-up should be done every 6 to 12 months to monitor for glaucoma. Thank you. There can be the features, the distinctive features of each of the differential diagnoses like eye syndrome and AR syndrome may not be very distinct. So that will, the splitting of fibers actually helps us, and it is mostly confined to the inferior region. So the management may also be different in cases. For example, in eye syndrome, doing a trabeculectomy is associated with the increased risk of failure because there is growth of the membranes in the superior area blocking the ostium. So that can be managed, which is not seen when patients with iridochisis. Yes, ma'am. It helps to differentiate the condition so that our management can be better suited for that particular